Well, welcome everybody to Orthopedic Physical Therapy Research Day. I really appreciate you guys being on either online or in person. We have two of our graduating residents here today presenting their research results. Our first is Dr. James Ritter, and he did a study on orthopedic residency training outcomes. And our second presenter is Dr. Matthew Kosar, who did a study looking at odd presentation of a patient with slipped capital femoral epiphysis. So without further ado, I will turn it over to them.
Well, thank you, Steve, and thank you everyone for coming this afternoon. I appreciate it. I'd also like to say special thanks to Hannah Stitt, who was willing to come out. For those of you who don't know Hannah, she's literally about to give birth any day. So if the prospect of a woman's water breaking in the middle of a research presentation doesn't excite you, I'll be honest, I don't know what will. So as Steve mentioned, my study was, does orthopedic residency training result in improved patient outcomes, a retrospective case-controlled study? The presenter, unfortunately, does not have any financial disclosures to make. At any point, if anyone would like to change that, by all means, please raise your hand or let me know. I will happily sign just about any contract. Residents cannot afford to be choosy. So just a little bit of background on why we were interested in this presentation. So as you know, physical therapy has come a long way since its roots. Many people argue that initially we were pretty much technicians, and since then we've come all the way along to a doctoral profession. And with that increase has also come an increased opportunity for direct access, which has been fantastic for our profession. However, that has also come with an emphasis in being considered the musculoskeletal experts as well as the movement system experts. This increased pressure, arguably pressure, has made clinicians have an increase in desire to continue education and to continue to move forward from a professional standpoint. This then begs the question, what is the best way to increase their clinical expertise? Catherine Smith in 1999 said that healthcare organizations across the country are seeking to place the most skilled practitioners at the first point of contact for the patient in order to decrease duplication of services, decrease costs, and increase patient satisfaction. Even though that was in 1999, that still holds true today, and it's still something that as a profession we are moving towards and working towards. So as you are well aware, clinical expertise has been considered one of the key aspects of our profession, especially if we want to move forward. There are a couple of areas that make up clinical expertise, and that's continuing education, clinical experience, knowledge, and critical reasoning. So we want to consider what is the most effective and what is the most efficient way to help us as clinicians to increase in each one of those areas. So Bren in 2006 did a study in which 34 of 57 physical therapists performed a 2-day education course. This course was specific to patients who had neck pain. During this study, they essentially took 1/3 of those individuals who attended and had them continue on with extra mentoring, or in this case, they called it an improvement project following the continuing education. They wanted to see, was continuing education enough to have a significant change in patient outcomes, or was additional mentoring needed? From this standpoint, they found that those who had attended the course did not have a statistical increase in their patient outcomes. However, those who attended the course and then continued on with additional mentoring by the individuals who did the course excuse me, did have a statistical increase. This led to an additional study in 2009 by Cleland, who once again wanted to look at continuing education and is it enough to help us improve our clinical outcomes. The group was split into two different cohorts, one group where people went to, again, a 2-day course, and the other group where they went to the 2-day course and then had additional mentoring at weeks 4 and week 7. Again, in this study, they found that the mentor group had superior results. In fact, the mentor group was the only group, once again, that had statistically significant increases in patient outcomes. And I'd like to point out this flow sheet here. If we look at the bottom two areas for those receiving ongoing education and those who did not receive ongoing education, you'll notice that those who did not receive ongoing education, and again, in this case, the ongoing education is the mentoring, they had 16.4 average years of experience, where those who did have the ongoing only had 11. Despite the disparity in experience, those who had the ongoing mentoring still had the superior outcomes, suggesting that perhaps the experience was not as heavily weighted as we may have expected, and also once again highlighting the importance of the mentoring. This brings me to the point of residencies. If we look at this information here, we actually will find that residencies have a key component of mentoring. As you can see, we have 150 hours minimum of one-on-one mentoring. And this information comes from the American Board of Physical Therapy Residency and Fellowship Education. Go ahead and say that one 5 times fast. However, we do want to again point that from the education standpoint, we are working on all those areas we talked about that increases clinical expertise. If we look at the core competencies of the residency programs, we'll see once again those areas that we highlighted and talked about. So I want to highlight this chart here, which talks a little bit about the mentorship program. If we look at the top in the D1 position, essentially the person who is the expert or the one who is doing the mentoring does a particular skill or a particular activity. The learner then is watching and learning from the mentor. As we move into the D2 position, the mentor is doing it and the learner is helping out. As we move into the D3 position, once again, in this case, we actually have a bit of a role reversal. The person who is learning is now the primary doer and the mentor is simply assisting and helping. As we move into the fourth dimension here, we actually find that the individual who was the learner is now the one who is primarily doing the skill or activity. And so this highlights kind of the pathway of mentorship and how an individual can go from a novice to an expert, and each one of these areas allows additional reflection and conversation about how those topics were done. This topic this quote by Worthingham kind of once again talks about not only the importance of progressing as physical therapists, but also in our relationship with other healthcare practitioners. And yes, this quote was from 1970. However, this quote still holds true today, where we do want to continue to move towards mutual respect, including our other healthcare practitioners, as well as increasing our responsibility. And so then, if we know that continuing education is potentially not quite enough, and we know that residency training has a significant mentor aspect to it, is residency training beneficial? And I like this image because, as we see here, the word evidence is only worth 14 points, which kind of concerns me a little bit. I like to think, evidence is worth a little bit more than 14 points, but whether that's a societal issue or a Scrabble issue, I'll let you guys, kind of figure that one out. So this survey done by Smith in 1999, we had 100 residents who were surveyed post-residency. And essentially the results showed that they had a significant increase in confidence in regards to their ability to do a thorough examination. They also had a significant increase in their confidence to communicate with other healthcare practitioners. As we noted from our quotes earlier, both of those areas are very important in regards to our ability for direct access and patient care. A study done in 2017 showed from a residency standpoint, as you can see here, a test was done, and to give you a little bit of information on that test specifically, there was a test that was adapted from the American Board of Physical Therapy Specialties Dimensions, and this had 58 different items in examination, evaluation, diagnosis, and prognosis. In this case, this test was also done over 5 days, so it was a pretty rigorous test. We had 12 residents, and we had 10 experienced matched PTs, and we can see here that the pass rate for the residents who had gone through the residency, was at 83.4% versus no one passed who had not been through the residency. So while these are pretty dramatic results, it does once again highlight that the residency training and specifically the mentoring in it can certainly help increase our competency. So this led us to our problem or our question: how valuable is residency training to our patients? And our hypothesis was that residency training results in superior patient outcomes. So in our methods, we chose residents who had 6 months of data prior to doing a residency because we wanted to see, did their outcomes improve after the residency. We then also controlled for matches who had a similar amount of experience and a similar educational background. I do apologize, we decided not to list all the educational background of those particular clinicians because otherwise then you would be able to find out who they were because their profiles are public. So we decided to protect the innocent, so to speak, in that case. We also decided that we were going to utilize photo as that is a validated source, which we'll talk about in just a second. We also wanted to make sure that our methods include residents who had a year post-residency, so we could look at their outcomes. And it was also important to note that both our residency group and our control group had an N of 3. So here we have some information specific to photo. I won't go through all the different studies, but as you can see, there are multiple studies that have validated photo as a resource and as a tool to allow us to compare outcome measures between therapists. We also wanted to point out that the subject starting points, so we had a range of starting effectiveness of 20 to 40 amongst our cases and our controls. It's important to note that the effectiveness is how much better you can get your patient or how much improvement on the outcome score that they were able to have. So it was interesting to note that our results, that we did not have an average starting point of residents. And so this kind of showed that there was a statistical significant difference in between our controls and our residents themselves. This was pretty surprising to us because we expected, since they had a similar amount of experience and a similar educational background, we anticipated they would have a similar starting rate in regard to their photo scores. Ultimately, post-residency, those who had been engaged in the residency had a 22-point average increase in their outcome measures compared to our control, which again suggests from a positive trend standpoint that doing a residency may certainly help in outcomes. So for further research, we're suggesting that perhaps it's a better way to case match your subjects from starting photo scores as opposed to the educational and experiential backgrounds, since as we found, there was a differential. We would also suggest additional subjects for improved power. So some of the limitations, again, goes back to our subjects, and then also the potential for non-standardized implementation of photo. Since this was a retrospective study, we weren't able to control how photo was utilized in each one of those cases. From a conclusion standpoint, we were able to find that residency training does increase value for our patients, and we were also able to find that residency training does lead to superior outcomes. At this time, I'd like to thank Dr. Stephen Kareha and Dr. Rhett Holmes, both of who were instrumental in helping me do the research. I can honestly say if it wasn't for both of them helping me out, this research project would not have happened. Here are my references. Anyone have any questions?
Higher or lower, or are they comparable?
Yeah, so in that case, we actually ended up finding that the residents had a significantly lower starting point than their controls.
And then at the end, it was 22.5 controls.
On average, yes, ma'am.
Okay. Yeah. That's a big difference.
It is. I mean, again, we can't claim statistical significance just because of our low number, but certainly from a positive trend standpoint, we were very encouraged by that. Thank you for your question. I appreciate it. Anybody else? So I think maybe one of the biggest things to do differently, I think the way we case matched, I would definitely change. I think that would be the biggest one for me. Again, like I mentioned, going away from just the educational background and experience, but more to starting photo scores. I would also like to see just an increase in the amount of subjects available, and that is a challenging aspect from this standpoint because obtaining data from clinicians is not always easy, especially when you need a very specific period of time. Individuals who also start working as a physical therapist, go into residency, and then have graduated and have about a year afterwards is also a pretty rare cohort to look at. Right now, there's about 3,903 residents who have done residencies anyway since they first started in 1999. So it's been challenging to find that data. So I would like to see an increase from that standpoint as well. Yes, ma'am.
Did you control for any other factors that put people in photo if they weren't with an assistant or things like that?
So no, in that case we did not. We did not look into if they did have a PTA or not.
Though it wasn't one of the controls, however, it ended up being controlled for based upon sample size and what we know of the sample. Because the three people, we know who you guys are. So looking back on it, effectively it was controlled for, but that was not the plan.
Good question. Thank you. Is that maybe a question in the back? Oh.
So the data that you looked at was 6 months prior to starting residency and then a full year after completion. So you had looked at in residency.
Yes, ma'am.
What made you choose a year after? pre and a year post workout? Choose those parameters.
Sure, yeah, it's a great question. So in that case, we wanted to give enough time to kind of see some of the difference. And so the other aspect too is some of those subjects, just because the way photo works, as you discharge them, that's when the information goes in the photo. And so if part of that individuals were being discharged that had been during the residency, it wouldn't quite give us only the post information. So we wanted to have a little bit increased time to capture that data a little bit better. Yes, sir.
Besides the residency, do you think that there are other factors that differentiate the people in the study?
It's certainly very possible. I mean, I cannot claim to know each one of those very well personally, but certainly, we know that, like, for example, the therapeutic alliance certainly impacts, outcomes as well. So I think that would also be an interesting study. It would be challenging, I think, to control for and try to get the data. But if we did find that individuals had better therapeutic alliance, that probably would impact it as well. And which I'm a little biased in this case because of the study, but it is possible that perhaps the residency helped increase that therapeutic alliance as well, which may partially be an example of why those scores increased.
We have to look at other education that non-residents went to, or if they did they go down other educational education, right?
Yeah, so we did look at certifications. We looked at both, kind of pre and post. So if they had additional training or additional certifications before, we actually ended up removing them from our study. Just because we wanted to keep the playing field as even as possible. We did that both for our residents and our controls. Afterwards, we did note in regards to some of their additional certifications and things like that. All right, thank you guys very much.
And next we have Dr. Matthew Kosar.
All right, so thank you all for coming. Thank you all for watching on Skype. James gave a shout out to Hannah, so Nick emailed me this morning personally letting me know he wouldn't be here because his car broke down. So he's watching on Skype. Thanks, Nick, for watching. All right, so my research project was on imaging report on subcapital femoral epiphyses masquerading as a quadriceps strain. So this patient was actually Jesse Buggies, so I want to thank him personally for allowing me to do this imaging report on one of his cases. And I also want to thank Dr. Stephen Kareha for helping us formulate this project and helping us submit it to JOSPT. All right, I don't have any disclaimers. So the case starts off with a 14-year-old male, presents to his pediatrician's office. I believe it's like the middle of May. He had left anterior thigh, upper thigh discomfort with activity for about 10 days. When a pediatrician eval'd him, he had no tenderness or palpation in any of that area that he just had his discomfort in. He did have some pain with hyperextension and flexion of his hip. There was no discomfort with any hip rotation. There was no swelling, no ecchymosis or erythema. He did have abnormal gait. In the pediatrician's note, luckily we were able to see some of it with Epic. She didn't describe it at all. It was just abnormal gait. And then he did have overall good lower extremity strength and range of motion. So based on all that she found, she diagnosed him with a left quadriceps strain. Just some things to note. His BMI was 24.3 kilograms per meter squared, but because he's an adolescent, it's better with the percentile usage. So he's in the 88th percentile, which is actually the overweight category. And just for your reference, 95th percentile is when you get to hit the obese category. He's also supposedly very active. He weight trains as well and denies any specific incident leading to these symptoms. So because she diagnosed him with a quadriceps strain, I just want to briefly go into what an actual quadriceps strain diagnosis entails. So quadriceps strains usually are caused by sudden forceful eccentric contractions of the quad, like kicking, jumping, sudden change in direction while running, and they typically present with anterior thigh pain, tenderness of palpation anywhere throughout the quad, pain with resistant muscle testing of the quad or hip flexion, and pain with passive stretching. Just some other facts about it. The rectus femoris is the most common quad to be strained, which makes sense because it's the two-joint muscle. The location of the pain can be anywhere along the quad, like I said, but classically it's described along the distal portion of the rectus femoris at the musculotendinous junction. However, several studies have shown that it can commonly occur at the mid to proximal portion as well. So knowing all this, going back to the pediatrician's exam, there's really nothing matching any of the thing that matched with the quadricep strain. So anterior thigh pain he does have, but there was no tenderness to palpation, no pain with resisted strength, no pain with passive stretching, other than the hyperextension of the hip and the flexion of the hip. Something to keep in mind. And these are just the classic grades of strains, which applies to every muscle. You have mild, moderate, and severe. So then going to the physical therapy consultation, which was, I think, 2 or 3 weeks later after the pediatrician's visit. He did have some more information with the subjective. He found out that the patient recently started weight training as part of his football training regimen, and now his primary complaints are pain with standing and sitting for prolonged periods, and his now pain is in the lateral hip as compared to when it originally was in his left groin. So for some of the objective findings during the clinical examination, he had normal left hip external range of motion, both actively and passively. He had significant left hip internal rotation and abduction range of motion limitations. Specifically, the left active hip internal rotation was 10 degrees and painful, left passive hip was 5 degrees and painful, and left passive hip abduction was 0 degrees and painful. Just some other notes, his left passive hip flexion was 100 degrees and painful in the supine position, and his right hip was normal passive range of motion throughout. He had decreased left hip abduction and internal rotation strength. Specifically, abduction was 1, and internal rotation was 3- on the manual muscle test scale. This correlated with his inability to abduct his leg in a supine position. He also had the inability to flex his leg in a supine position, but his flexion strength was a 4-, but that was measured in the seated position, which is the typical manual muscle test for hip flexion. All of other manual muscle tests for the right leg lower extremity were 4+. He had normal and pain-free left knee extension strength. That was 4+ as well. He had a positive fader, and he had an antalgic and Trendelenburg gait pattern favoring that left side. So because of all these pertinent objective findings, there was a suspicion of a slipped capital femoral epiphyses, and I'm just going to call it SCFE from now on because it's kind of a mouthful. So just a little background information on SCFEs. It is the most common hip disorder in adolescents. It's 10.8 cases per 100,000 children per year. The age of onset is 11 to 15 years old for females and 13 to 15 years old for males. It is actually more common in males, 2.4 times more likely to be precise. It typically happens in overweight prepubescent adolescents or tall, thin, and athletic adolescents. And 18 to 50% of the cases are bilateral in nature. So the typical SCFE diagnoses, the history and physical exam, the patient will present with limping, pain in either the hip, groin, thigh, or knee aggravated by activity. He has limited and painful hip range of motion, primarily internal rotation, but also limitations in flexion and abduction. He has decreased hip, the patient would typically show with decreased hip strength, internal rotation and abduction, toeing out during gait, and Trendelenburg gait pattern. So just based on looking at all those and going back to the clinical exam that the physical therapist completed, you can kind of see it matches almost perfectly. He had decreased hip internal rotation range of motion, decreased hip abduction range of motion, antalgic and Trendelenburg gait, and decreased strength, specifically of internal and abduction. So to diagnose these, imaging is bilateral, and it's AP and frog leg radiographs of the pelvis. So this is a picture, radiograph I found online. Basically, the point of it is to demonstrate what these lines are. So these lines are called Klein's line or line of Klein, and it is drawn along the lateral aspect of the femur, and this line should normally intersect the lateral part of the superior femoral epiphyses. So, there we go. So right here is that line of Klein, and then this is shows you the level, how much it is from that line to the superior part of the lateral epiphyses. The yellow circle is just a femoral head. It's a little fuzzy in the original picture, and I couldn't really adjust it with the contrast, so I just put in the yellow circle so get a reference of where that is. So, and then the line of Klein is disturbed with a SCFE. The epiphysis is malaligned with no intersection of the capital femoral epiphyses. So this one on the right hip is still intersecting a little bit, but you can still see it's way less intersecting as compared to be, indicating a slip is either happened or it's very prone to happening in the near future. So pathophysiology of SCFEs, it's usually due to weak growth plates of proximal femoral physes. It's due to shear forces which cause displacement of the epiphysis off the femoral head. The epiphysis moves posterior and medial, and the metaphysis moves anterior and lateral. Because of that, the metaphysis and the lower femur externally rotate relative to the epiphysis. And this correlates with why when you examine someone with a SCFE, they have normal external rotation range of motion, but when they have severely limited and painful internal rotation range of motion, because you're basically just pushing that slipped off bone into the other bone. And it's classically described as an ice cream cone. I don't have the picture in here, but it's a typical presentation of it. So the prognoses of a SCFE. Stable SCFEs are treated with in situ pinning procedure. I never know how to pronounce that situ word, but it's good to excellent long-term outcomes. Osteonecrosis is rare if treated, less than 10% actually. However, it is more common if it is not treated. And the prognosis is worsened by delay in the diagnoses. And there's also something called an unstable SCFE. Hopefully we never see these in practice, because unstable SCFEs, the patient cannot even weight bear on that hip, so hopefully it's diagnosed pretty quickly. But with that, the prognosis is worsened, and also the chance of having osteonecrosis is increased. So back to the patient case. Immediately after that initial consultation, physical therapist made a call to the referring pediatrician requesting orders for radiographs. He went immediately to the pediatrician and had the AP and frog leg radiographs obtained that day, which revealed asymmetric widening of the left femoral epiphyses, which correlates with a Salter 1 injury or an early slipped capital femoral epiphyses, SCFE. And then these are his pictures. I'm going to blow them up in the next slides. So this is the AP view. And as you can see, it's the line of Klein I was talking about earlier, and there's absolutely zero intersection with the superior portion of the lateral part of this femoral epiphyses. And then this arrow indicates that slippage. You can see how the epiphyses slipped off the metaphyses. And then on this side, he actually is prone to another one, it looks like, because there's barely any intersection there, but there's still a little bit more than that side. And then here's that AP frog leg view, not AP frog leg view. And you can see again, just outlining that slippage a little bit better on this view as compared to the AP one. So the patient was subsequently referred to an orthopedic surgeon, who further referred him to a pediatric orthopedic surgeon, and the patient was admitted for a SCFE in situ pinning procedure within 24 hours of that physical therapy consult. His restrictions post-surgery, based off that doctor's note I read, were no sports, gym, playground, running, jumping, climbing, or other fall risk activities. He was toe-touch weight-bearing on the left lower extremity with the use of crutches, and he was supposed to use the elevator and have a book buddy in school. Then he had a post-op visit about 4 weeks later, and the doctor told me he was able to swim and bike, but he still had to wear the crutches for 2 more weeks, so that would be a total of 6 weeks on the crutches. But he still should avoid sports and high-impact activities at this time. And then they anticipated him returning to sports in about 5 to 6 months. Now, like I said before, how he looked like he was prone to having another SCFE. Actually, when I went back in his chart just to make sure I had everything right, he had another SCFE about a couple months ago on that right hip, and he had the same thing done on this right hip. So, and then in conclusion, this case shows the importance of a thorough examination and subsequent imaging due to suspicion of a more serious pathology. And these are my citations. And any questions, concerns?
Do you think the physical therapist could order directly would save any time or effort?
I believe so, but I think because he got referred by his pediatrician, he felt the need to go through him, so I didn't feel like he was overstepping. But yes, I do think that would have saved some time, especially since he was referred to an orthopedic surgeon in our network anyway, so it would have saved a decent amount of time. But I think 24 hours within the initial physical therapy consult is very impressive to getting into surgery.
Now, with the possibility of the other going out, the physician released it, like, amazing to me.
He didn't. I'm sorry.
He released it before.
At 5 to 6 months he did. So this was surgery was, I think, like end of May. So he wasn't clear for sports technically until October, and that's actually when October is when he had his other one.
Okay.
So
So do you feel that if they would have done preventative pinning would have been helpful, or do you think that the intelligent gait was what ended up causing it?
I think that, well, because it wasn't symptomatic, I don't know if they believed to do it at that point, but because of how it's literally almost about to slip off right there. So I think it would be a bit warranted if they decided to do it. But I also believe that how his walking, putting all that weight on that right leg, probably predisposed him. But also the fact that he also gained a lot of weight in this time, because when I was putting in all his information, I put in a BMI for October, but then I should have put it in. Well, the one I did put in was what he was in May, but in October I believe he was in the 90th percentile just for so. Basically, any of the adolescent kids who are prepubescent and more obese or tall, thin, and athletic. Like I said, let me see. Basically, it's more common in males. The more active population typically occurs in, but also if they're obese and active, it's probably more prone because they're putting all that weight through their legs. And also, this patient case, we found out he did start weightlifting for his football, which I don't believe he started. This is the first year he was actually doing this, so it's completely new to his body. So that might have predisposed him as well. But it is common in that young adolescent, active, obese, athletic population, yeah. Honestly, I don't know, but I would assume that if they're muscular, they're able to support the load a little bit more. It's just how gradually they get into it. So if they go 0 to 100, like this kid did, I can only assume he did, that would predispose them more because their bones aren't used to it, because when they're young, the growth plates are more weak than the ligaments. So that predisposes them to a lot more injuries in that growth plate area. But, yeah, that's actually a good question. Not that I found. I would assume, because always strengthening the hips is always a great thing for everybody, glutes and glute med, but I don't know if that predisposes them just because of how you can't make the growth plate stronger. So.
What percentage goes to osteoporosis?
Anyways, I know I said less than 10%, but I think it's very rare. The unstable skiffies, they do a whole new different procedure. They do an osteotomy and all that, so it's definitely higher in that percentage. But it's very rare that, especially if they get this done quickly, it's maybe like less than definitely 5%.
So do you mean if 1% goes to osteoporosis, it's not treated?
Well, either. I come from the old school, that and the incidence was pretty high. And so less than 10% is way better.
And I think that's correlated with the quick diagnoses and able to get that pinning in there, so it doesn't affect the blood supply as quickly. So that's why if the prognosis is delayed, that epiphyses is slipped off, and that part's not getting blood as much, which leads to the greater chance of osteonecrosis. Which is also why unstable is worse, because unstable is basically it's off and unstable. There's no.
So now, since Jesse had been through the residency program, was better able to diagnose.
I'd like to make that correlation, but I'm not sure.
See if there's any questions. Does anybody online have any questions? For either person.
For either person, any questions online, people? No.
So this concludes research day. If anybody has any questions, feel free to stick around and ask. Thank you guys for all joining us online.